So I'm gonna go and record this. Okay, so today we're gonna be covering the second part for chapter 14. Then we're gonna go over chapter 15 and 16. Now, 15 and 16, shock and resuscitation and respiratory emergencies, are kind of a little bit long, um, but we'll get through them. Let me see. So, do you guys have any questions so far? Good. It's pharmacology. We're gonna finish pharmacology first. Where's pharmacology? Just chapter 14. Okay, there you go. Okay, so this is a continuation for pharmacology. Um, and we went over some of these medications. Of course, this one we already gone over, but it's naloxone, or like a couple of friends of mine call it Nalex 1. Basically, it's Narcan. And I think everybody and their dog is carrying it because of the fentanyl situation that we have. And this can actually be given intranasally. And what it does, it competes for the sites that most of these opioid drugs are affecting. So it competes with it. It'll push the opioid drugs receptors out of the way, or not the receptors, the input keys. Now what happens is that it works, but it does not last long until you're actually. Is that what said that right? Oh yes, I did set up Google Classroom already, so you can go. I send the invitation. You need to accept it. So and I put everything that's on there, including the answer sheet for the test. But I put everything, all the assignments and everything up to date, and I also place on there the Zoom video links, so you can go there and just click on it, and it'll take you. They're not in order because I think I went backwards, uh, but it's beneficial for you to actually have that, just in case. So basically, it competes with it. The thing is that it doesn't last long. So uh, what I learned to do was basically titrate it. Okay, and by titrating, you give a little bit until the respirations come up to normal. So if we know that you give it, sometimes you don't want to fully awake this guy for the simple reason that they might become combative, and when they become combative, they're combative because you ruined their $15 high. So and they get pissed. So and I remember I told you I was gonna show you a video and I forgot about it. As soon as I finish this, I'll look for that video. So Narcan certainly reverses the respiratory depression, hypotension, and sedative effects created by the opioid overdose. So these medication names, they're based on different things: the chemical name, generic name, the trait name, and the official name. So I'm going to give you an example. Chemical name 1,2,3-propanol trinitrate, and basically the generic name is nitroglycerin tablets. The official name is nitroglycerin tablets, and when you see official name, the words USP appear right afterwards. And this is basically stands for United States Pharmacopoeia. Even the oxygen tank has to have a USP because we need to give oxygen that is medical grade. So the trait name would be nitrostat. And honestly, it seems kind of confusing, but it all has to do, with the law and all these other things like aspirin. Aspirin is also known as salicylic acid. Okay. Of course, you can once you start dealing with the generic name would be aspirin. The trait name could be Bayer's aspirin, or it could be Walmart aspirin, or it could be um, what's his deal? HEB aspirin or whatever, right? So oxygen, trait name, there's nothing. It's just oxygen, right? But it's used for hypoxia, hypoxemia. Now, the chemical name would be what? O2, right? So it's strict hypoxia, hypoxemia, poor perfusion, shock, respiratory distress, dyspnea, heart failure, altered mental status, and if the SpO2 level goes below 94, or upon an unknown oxygen saturation reading. In other words, if you don't know what he's saturating at, you can actually give oxygen. Glucose, oral, also known as glucose, instant glucose, is for altered mental status associated with hypoglycemia. Now, we do have what we call a coma cocktail out there. And the coma cocktail basically is everything, the medications you're going to get for altered mental status associated with hypoglycemia, or for unknown reasons, I think. With let's see, if you give thiamine, then basically it's a glucose issue also, because thiamine helps glucose get into the cell. And thiamine is a vitamin, but we also give thiamine also, also known as vitamin B1. And we also give Narcan, because we don't know if they're unconscious um, because of they're hypoglycemic or they're going through a drug incident and whatsoever. So there's like 4 drugs that you can actually give. Activated charcoal is Superchar, Instachar, Actidose, and Liquichar. It's usually for the ingestion of poisoning emergencies. Nitro, also known as nitroglycerin, also known as nitrostat, is for chest pain and cardiac origin. Nitroglycerin spray is also known as nitrolingual spray, because basically you just spray it under the tongue, and it's also for chest pain of cardiac origin. Epinephrine, also known as adrenaline, EpiPen, AlBQ auto-injectors. Okay, and this is for anaphylactic reactions. When you're, what do you call it? The allergies become bad. Now, I hope you guys know the difference between allergic reactions and anaphylactic reactions. We went over them last year. Albuterol, also known as Proventil, Ventolin, ProAir, Acuneb, and Wolfspire. And basically, this is for breathing difficulty associated with respiratory conditions and bronchoconstriction. So what it does, it bronchodilates. And what that means is that it opens up the lungs that are closed, the airways that are closing up, it opens them up. Levoalbuterol, also known as Soponex, which is also for breathing difficulty associated with respiratory conditions and bronchoconstriction. Hypertronium, bromide, or albuterol, I think there's an L missing there, is combinant Nuvoneb, also for breathing difficulty associated with respiratory conditions and bronchoconstriction. Aspirin, also known as Bayer aspirin, Esprin, Ecotrin, Emprin, I'm sorry, Ascriptin, and Buferin and Bufix. Now, I didn't know the Bufix and Buferin, I didn't know that, but if patients who are experiencing chest pain of or chest discomfort suggestive of an acute coronary syndrome. So if they're experiencing chest pain, the key thing, guys, that you're looking for when you want to give aspirin and nitro is if they're doing this. They're trying to grab their chest. Okay. That's a telltale sign that they're actually going through a cardiac compromise. Naloxone or naloxone or hydrochloride, also known as Narcan, Narcan nasal and spray, and Envisio. The Narcan nasal spray is the one that everybody's carrying. Police department, border patrol. You also see some firefighter departments carrying it. So you can go ahead and just inject it through the nose, and it kind of like misses it out, and you get it absorbed through the nose. There's some medications that you actually do give through the nose. It's for known or suspected opioid overdose. Now, what could tell you uh, that the person is actually going through a suspected opioid overdose? What can hint you? What would be your cheat sheet note at this point that you think this guy is going through this?
Foaming of the mouth and seizures.
Yeah, it could be. Now, the other thing is just the drug paraphernalia or the place that he actually goes to. I mean, where you found him. I know that when I was working as a paramedic, and I think I told you the story that we got called to this, supposedly according to the DPS trooper that was there at the hospital. As soon as we were about to leave, he goes like, just be careful. It doesn't sound like a good place. I'll meet up with you there. And I remember it was trooper, what's his name? I'll remember in a little bit. He became a real good friend of mine, older gentleman already. Uh, and we took off. Of course, we took off like a bat out of hell, going code 4. I mean, we were actually going way above the speed limit. And when we got there was no police or anything, and it was a call for a choking infant. So why would a police officer show up, right? So when we got there, I took out the portable radio. Now the portable radios that we had back then were about this long. They were the King radios. So I turned on the repeater in the ambulance. It was in the middle of a little town that we live close to. It took us about 15 minutes to get there because it's about 15 miles away. Uh, so once we got there, it was dark. I'm walking towards the front door, and I trip over something that I thought it was a piece of wood. So when we get to the door, this lady shows up. It's like, well, he's out there in the middle of the yard. And of course, it was pitch dark. It was about 10 o'clock at night. So I walked back, and I'm thinking, oh man, I just trampled this guy. And sure enough, I I didn't trample him. I tripped over him. We got there, and I'm assessing him, and he was like going at 100 miles per hour. So we brought out the Narcan. We brought out, because we didn't know what he took. You ask around, nobody knows. And then all of a sudden, I feel my partner tapping me on my shoulder. And I say, I'm dizzy. I'm trying to open up the airway. So he taps me again. He gets his flashlight, which was one of those big, humongous, long flashlights, and he turns it on. And we have an audience, guys. This was a group of people surrounding us. Okay. And they all looked like zombies. Okay. And the area that I was at, and I hate to sound like this, but it was an area that I would suspect was the initial point where all the tacuaches were born. You guys know what a tacuache is, right? Sí, quemaca. I guess you don't know what a tacuache is. Anyway, so we're there. It's just some people that have the same haircut. I mean, I got freaked out. So anyway, when I was there, I look up and I grab the radio, and this radio had one of those they call it super mic, where I had it in my belt. I clicked it and I said, I switched it to inner city, and I requested for police backup. And I swear, the person that answered said, "We're there in about 10 seconds." And he just hear the woo, and he stopped. And dude, when I looked up, there was nobody there. They all spread out like cockroaches when you turn on the light in the kitchen. And it was like, at first I was now trembling, right, trying to, calm down, because we went to a scene where um, we shouldn't have been in unless there was police escort. And guess who it was? The DPS trooper. His last name is Munsell. Uh, Pretty cool guy. So because we didn't know what he had taken. I mean, he was going at 100 miles per hour. If he had taken fentanyl, because fentanyl did not, it did exist back then, but it wasn't a recreational drug, uh, he would have been unconscious. This guy took something different that caused him to go at 100 miles per hour. So Routes of administration, the places that you're going to be putting in these drugs in is given to or taken by the patient. The route affects how fast this is going to get absorbed. Each medication you administer is prepared in a form that allows the quickest and safest absorption into the body. Remember, there were some of them that you intranasally, right? So we have or sublingual, which is under the tongue. That is a very quickly absorbed drug because if you look under your tongue, you have blood vessels that are very superficial. And what happens is when the medication is lying on top, it gets absorbed into the bloodstream. Oral is basically you're taking like an aspirin oral and then you're swallowing it. You inhale it like a nitrous oxide or oxygen. Intramuscular injection basically is an injection goes straight. And I know one of the most common ones that we give intramuscular is oh, I forgot what it is called. It's a diabetic medication, which is not insulin, but it's the second version of insulin that helps us actually get sugar out of the system. And I'll remember it in just a little bit. I'm brain fried right now. Uh, but this medication is given straight into the muscle, intranasal through the nose, and subcutaneous right below the skin. Okay. And glucagon, it's a medication that we give for intramuscular injection for somebody that's hypoglycemic. Because we want to give them sugar, but that sugar is going to be absorbed real fast. So when we give them glucagon, and the glucagon will actually cause the body to release whatever sugar it's got stored, whether it's in fat form or whatever. So sublingual medications is placed beneath the patient's tongue where it's absorbed, is dissolved and absorbed, used only in alert patients and used to administer nitroglycerin tablets or spray. Oral, the drugs is swallowed for absorption through the gastrointestinal tract. And the majority of the time when we talk about gastrointestinal tract, where do you think this drug gets absorbed? Does it get absorbed in the stomach, small intestine, or large intestine? It's absorbed in the small intestine. That's where most medications are absorbed. Now, if you have alcohol associated with like some cough medicines or whatever, it's kind of absorbed quickly into the what do you call it? The stomach lining, but chances are most of it's going to be absorbed through the small intestine. So we do have this uh, medication also known as activated charcoal. That is not absorbed. So we what we do is if we suspect somebody took something that you don't want it to get absorbed into the body, you actually give activated charcoal. And that activated charcoal lines the lining of the small intestine, which prevents anything to get it from getting absorbed. Now, the only bad thing is you're going to have very dark stool. But the good thing is now it comes in strawberry flavor. Okay. Now it's also used only in alert patients. It's used to administer aspirin, oral glucose, activated charcoal. We also have inhalation, which is used for gases or aerosols. Medication is inhaled into the lungs for absorption. Is used to administer oxygen, and medication is given by metered dose inhaler or small nebulizer. And these are the ones that you actually put together and you basically pump it in, or you have the nebulizer, which is nebulized into the system. Intramuscular, you inject it into the muscle mass for absorption. It requires use of a needle, some discomfort to the patient, and is used to administer epinephrine by auto-injector at your level. Okay, intranasal, the medications is sprayed into one nostril or both nostrils. You have the mat, which is basically a device that kind of like, what do you call it? Atomizes the the medication. And when we're talking about atomizes, like it just gets it real fine so it can get absorbed through the nasal cavity. Um, Actually, it creates a fine spray of drug particles of a specific size that actually stick to the mucosal lining. The medication cannot be absorbed without this MAT mechanism. Okay. Subcutaneous medications that are injected under the skin into the subcutaneous layer. They produce a slower absorption rate than intramuscular injections and can actually be used after an intramuscular injection of Narcan to actually prolong the desired effect of Narcan. Remember, if you give it intramuscular, it gets absorbed through the blood vessels in the muscle. But if you give it sub-Q, it's going to take a little bit longer. So now you have a longer lasting medication. The form usually limits administration to one specific route. Common forms include compressed, powdered, or tablets. And these are like your aspirins and your Tylenols and everything like that. Now, aspirin in pill form may actually be administered for chest pain when the heart attack is suspected. Now, the aspirin that you should have should, well, the medication, the dosage itself, do you guys remember the dosage for aspirin when it comes to giving it um, to patients? It's actually 324, I believe, or 25 milligrams. Now, the key thing about the aspirin itself, when you give it, you need to make sure that it's non-enteric. So basically, it doesn't have a protective cover. The type of aspirin that once you put it in the mouth, it takes like battery acid because it doesn't have a protective barrier to where it's going to open up in the intestines, not in or in the stomach, not in the mouth itself. Common forms include liquid or injection, also liquid substance with no particulate matter, like your epinephrine auto-injectors. Now you have with epinephrine, you have two kinds, the adult and the child. The adult is usually 0.30 milligrams, and the child is half of that, which is 0.15. Okay. Common forms are the gel itself, which is the glucogel, and this is a glucose or actidose, which basically you take off this little tab and you put in between the cheek and the teeth. And the thing is that it does get absorbed, but you need to make sure that this guy is not unconscious. Suspension, which is mixtures that do not remain mixed. You have to mix them up. And I know the most common ones that I dealt with were antibiotics. When you're trying to inject somebody with penicillin or whatever, it comes in a vial that is oily, kind of mixed, and you need to really shake it in order for it to get injected in. Activated charcoal also is administered in suspension form and is carried in some EMS units. It actually may be used for poisonings or overdose emergencies. And this one, basically, you just cut off the tip and you inject it into the person or put it into a cup and have them drink it. With kids, use a straw. Fine powders for inhalation also delivered by metered dose inhaler. And these are the ones that you basically use to pump in the medication into the patient. Now these are extenders. This is what it normally looks like, and they have to shake it for about 10 seconds before they actually administer because it's a powder that's actually mixed up. So now these are just spacers, but there's something like a spacer that looks like a Venturi tube, and that's not used in this type of situation. But small volume nebulizer use a compressed gas to form an aerosol of a mixing in the mixing chamber. And the aerosol is inhaled by patient through a mouthpiece or face mask. This is basically your albuterol setting. And yeah, you guys need to learn how to put this together. The medication goes in here and it's mixed up, it's actually mixed up with oxygen that's coming out. And you can connect this to a mask or to the tube, depending on the age of the person. And this is given with 100% oxygen. Okay. Now, medication forms gas. Okay, and most commonly used by medications is in EMS is the EMS unit is the oxygen tank. Okay, common forms includes also sprays, which is droplets can actually be deposited under the tongue. And basically, these are your nitro pills or your nitro spray. For each medication, you must actually understand the following information: indications, contraindications, dose, administration, actions, and side effects. Okay. Indications, the most common use of the drug in treating a specific condition. It's geared towards relief and signs and symptoms of a specific condition. Contraindications is the reason you don't want to use it. It's a situation in which a drug should not be administered because of the harm it can actually cause. The dose is the amount of medication you're going to give into the patient or give into the patient. Administration is the route. So it could be, okay, I'll answer that question. Basically, it's asking, sir, so so as far as being an EMT basic, what meds are we able to actually use to the patient? And basically, uh, the medications that you actually give are the ones that we're talking about right now. The only the only one that you need to worry about is a meter dose inhaler. It has to be owned by the patient. Albuterol, in some companies they do carry it. Some other companies they do actually don't. What do you call it? They in some companies they actually have to have a patient own that medication. The EpiPen, normally patients have it, but we do carry it. The medication for EpiPen is the same for all adults, and the same for all children. Now, when it comes to the other one, like not albuterol, but there's different concentrations of it. So that's why you kind of be wary about giving it unless the patient has a prescription to it. Actions is the effect of a drug has on the body. The therapeutic effect is what you expect this medication to do. So in the medication, let's say nitro, it should get rid of chest pain. That's a therapeutic effect. The mechanism of action is how the drug actually works to create the effect. Now it gets rid of the pain, but it's not an analgesic. You guys, an analgesic is a medication that is what do you call it? That relieves pain. Nitroglycerin is not an analgesic, it's a vasodilator. Now, it gets rid of pain by actually causing the heart to actually get some blood and oxygen. So don't get confused between those. Remember, nitroglycerin, you can only give it up to 3 times. Now, I remember there was a lecture that I went to in Florida, and I was told, remember that this is not an analgesic. If you still see an ST elevation or depression in the patient, you can give extra dosages, but that's because the ST depression and or elevation actually indicates that there's some type of ischemia or a heart attack. And if you get a medication and it doesn't get fixed, then you might not be giving the right dosage. So there's also what is the contraindication for nitroglycerin? Any blood pressure systolic blood pressure less than 90, you can't give it for the simple reason that it'll drop down his blood pressure a lot. Okay. Side effects, actions that you expect this medication to do. And the reason I talk about side effects is because I like nitroglycerin. Nitroglycerin, one of the side effects it gives is that it causes the patient to have a headache, a pounding headache, because you vasodilate a lot of blood vessels, including the ones in the brain. So it causes the patient to have a pounding headache. Um, and normally, what I'll do is nitroglycerin gets deactivated quickly through sunlight or exposure or whatsoever. So what I normally ask the patient, hey, when you normally take nitroglycerin, do you get a headache? And he goes, yeah. Hey, when we gave you this medication, did you get a headache? And if he tells me no, that means that the medication that he was taking is not working. Get it? Use this as a failsafe. It actually may be predictable or unpredictable. We're talking about the side effects. Now follow these steps in administration of the medication. Obtain an order from medical direction. Select the proper medication. Verify the patient's prescription and check the expiration date. Uh, check for discoloration or impurities depending on the medication. Verify the form, route, and dose. Check the 5 R's or the 5 rights for this medication administration and document medication administration. Now, what are the 5 rights when it comes to this medication? Right dose, right patient, right route. Um, um, I said route, right? I'll remember the other two in a little bit. Okay, obtain an order from medical direction. Every medication EMTs administer or assist with requires an order from medical direction. So you have to get in touch with the medical director unless he's got it specifically written down in your protocols. The order may actually be obtained online or offline, and verify an online order by restating it, repeating it to the medical director. Select the proper medication, read the label carefully. Many medications have several trade names also, depending on what you carry. I remember we had a medication that brought down blood pressure, and it was called nitrostat. It's a hospital-based medication. So it was kind of a little bit strong. And I remember when I gave a patient nitrostat, I turned around, the patient's talking to me, and then I just don't hear him anymore, and I just hear this, where he basically like dropped his arms to the floor because the blood pressure went down so far. So I went into panic mode. Sphincters got closed up, and basically, luckily, I didn't have white pants. When assisting with the patient's medication, verify that the medication to be given is prescribed to them. Now, don't fall under this typical valley-eyed situation when you have a grandmother that's taking a medication she's taken for years. She's a little kid. I know that the most common one, Darvonset or Darvocet. And they say, "Oh, you have a headache? Here, take this pill." Darvocet is very addictive. So I just got really freaked out that when we get to pick up the kids, they go, "Well, I took a couple of these pills that my grandmother gave me." So now I'm looking for the medication the grandmother gave them. And when I found Darvis, it's like, my God, you're trying to kill a flea with a cannonball. Okay. Check for the expiration date. Do not administer expired medications. Now, unless there is documented or documentation stating that you can, because in some cases that we had recently, and by recently we're talking about like 5-10 years ago, some medications were running out of some medications. So what we started doing is the Texas Department of Health turned around and told us it's okay to give it after a month of it being expired. So sometimes you fall into shortages. I heard that there's going to be some shortages of medications coming up also. Okay. Check for discoloration. Inspect for discoloration or cloudiness. Do not give discolored, cloudy medications to a patient because they might actually be not good. Verify the form, route, and dose. Use the proper form for the route selected. Make sure that the label matches the order from medical direction. This is the right fives that I talked about: right patient, right medication, right route, right dose, and right time. Now, I want you guys to memorize this because you might get it in questions, specifically when it comes to the National Registry. The documentation, the drug, the dose, the route, time, and changes in the patient condition. That's what you need to put in your patient report. I gave, let's see, albuterol to a patient that was suffering from respiratory distress. I gave him this amount. I gave him through, let's see, let's look for one that you actually need to have the patient's medication, which is a metered dose inhaler. I gave it at this time. and within 5 minutes, the patient started breathing better. Reassessment, check for mental status, airway, respirations, pulse, skin, and blood pressure. And these are the things that we're looking for to make sure that we didn't screw up. Okay. You must reassess the patients after medication administration for the SpO2 level that they have, changes in complaints, relief of signs and symptoms, medication side effects, and change in patient's condition. Sources of medication information: American Hospital Formulary, AMA Drug Evaluation, Physician's Drug Desk Reference, package inserts, Poison Control Centers, EMS Pocket Drug Reference Guide, which I would advise you to actually get. If you want to get a little bit fancier, download Hippocrates, which basically will give you everything. I used Hippocrates when I was in medical school because it will give what I liked about it is what drugs will actually interact with it. So other medical director approved websites that you can actually go to, but I like Hippocrates, and I see a lot of EMS people carrying the pocket drug reference guide. So questions at this point. So I'm going to show you something. Hold on. Okay. Okay, let me see. What? Hold on. Oh, let's see. Okay, so you guys are still all right. Okay, I'm gonna share this with you. Let me see. Hopefully, it's the right one. Okay, let's see. Okay, this is that thing that I told you about Narcan. Let me just make sure that I'm sharing the. Okay.
The heat. Let's go.
Gangster. Okay. You got
Really want one of these stars?
Of course, it's got
I
commercials.
think it'd be nice, yeah.
FX is the bear. All episodes now streaming only on Hulu.
There you go.
Get the hell out of my way.
Okay, what happened?
Please tell me he's gonna be all right.
No, he dead.
Bugging, we just signed our first record deal.
Look, he dead, son. Ain't nothing we can do about it. Come on, Frank, that's it.
What do you mean he's dead?
He's not dead. It's a heroin overdose. Let's break out the Narcan.
He's dead unless you folks want to stop bullshitting me and tell it straight. Then the good Lord willing will try and bring him back.
Broke up with his old lady.
We didn't break up. We were just seeing other
she
people.
broke his heart.
Shut up, asshole!
Tell me to
Nobody
shut up
asked
like
you.
you
I
know, Jules,
will
I talking to you.
Dead. I will. Shut up.
I'm still waiting and this young man here is still dead.
You want to leave here in a body bag, too?
You end up like him.
Shut up.
Dick. Shut up.
He's been snorting that red death stuff. It's been going on for like 4 days now.
Rebuke the spirit of drugs in the name of Jesus. What's his name?
I be banging.
What you mean I be banging?
I be banging.
What the hell kind of name is I be banging?
I don't know his real name.
Frederick Smith.
Okay, Freddie.
It's Frederick.
Okay, I be banging. We're gonna bring you back from the dead. Now, I want everybody here to grab the hand of the person next to you. Come on now, we ain't got much time. And look up towards the heavens. Dear Lord, here I am again, asking one more chance for a sinner. Please, Lord, bring back. I be banging, Lord. You have the power, Jesus. You have the might. You have the super light to spare this worthless man. Rise up,
Frederick!
I be banging,
Oh, my
and
God.
start your life anew, Lord. Oh, thank you, Lord.
What happened?
You fucking died, you stupid bastard. I warned you.
Damn, you guys are good.
Not us. The first step is love. The second is mercy.
Okay. Okay, let me see it. So let's go over the next chapter. That I think I showed you that one last year, but I'm not too sure. I won't. I'm not gonna remember. The what? Well, dude, that's Narcan right there. What he gave was Narcan, and they automatically knew that the person was going over this type of situation.
Is Narcan like one and done, or if they don't respond to the first one, can you do it again? Or
Yeah, you get the thing is that normally, because I haven't been a basic for decades. Um, what I would do is nowadays you guys don't even have to inject it in; you give it intranasally. But I would start an IV and have the IV ready, so I just push a little bit, see how he reacts within a minute, push a little bit more. But I would, because in my personal experience, I gave once the whole dosage, and the guy woke up like that, and he was pissed. He was like me, he was beyond pissed. He was like starting to like trying to throw punches and everything. And I learned, something. I moved back and waited for the medication to wear off, and he went unconscious. So basically, I just titrated it to the respirations that I wanted. Now, if your medical director or your protocol state that, then that's what you do. But a lot of people do the mistake of just giving the whole dose at one time. I mean, I would still leave the syringe there with some of the medication. So if I noticed that he was going down, I would actually give a little bit more. But then again, my experiences. So what we're going to be dealing with right now is shock and resuscitation. Everything that deals with CPR. There's a lot of questions on CPR when it comes to National Registry. So you guys need to go over everything that you have experienced with CPR, specifically the numbers, uh, the the compression ratios to ventilations, the age groups, how you're gonna do it, when you're gonna apply the AED. And I know that one of the most common questions, like when you find a patient, do you apply the AED before you give compressions or after you start compressions? So shock is a state of inadequate perfusion to the cells that actually can lead to death, and it's what we basically call inadequate tissue perfusion. The body's attempts to actually restore homeostasis results in many signs and symptoms of shock. And one of the signs and symptoms of shock that we normally deal with is pulse rate and blood pressure. Okay? Let me see if I can actually. So the pulse rate and blood pressure. With shock, pulse rate's going to be elevated and the blood pressure is going to be dropping down in the late stages. So you find somebody that has a pulse rate of 140, which is kind of very elevated, and a blood pressure of 90 over 60, the body's trying to compensate to maintain that blood pressure. Now, let's say if you have a person that has a pulse rate of 140, but he has a blood pressure of 120 over 80, then you actually have to suspect that this guy is going through shock because the body's compensating by elevating the blood pressure. I mean, the pulse that maintain the blood pressure. Once the blood pressure cannot be maintained, it starts dropping down. And that's not a good thing, guys. Okay, the body can attempt resuscitation is an emergency care provided to restore the vital body functions. And what you do is you're trying to maintain blood pressure by giving compressions and ventilations. Now, shock is defined as inadequate tissue perfusion or hypoperfusion, which basically means the same thing. Inadequate amount of oxygen and glucose are available to cells to actually meet metabolic needs. Inadequate waste products removal is also part of it. So you have, the CO2 that you're developing within the cells needs to get taken out. And the only way you can actually do it is by providing compressions that will circulate the blood around. And not only that, you need to get ventilation so you actually, when you blow in air, carbon dioxide comes out. Now, basically, this shifts the aerobic to anaerobic metabolism, results in decreased energy production and waste product accumulation. Cellular sodium potassium pump fails, and it's leading to cell death. Now, sodium potassium pump basically deals with a lot of the body functions that we have, including the nervous system. Once you start messing around with the sodium potassium pump, then you have problems. Okay, cell death results in organ failure, and once you have enough organs failing, you're dead. You're not a little dead, you're just dead. Okay, treatment for shock is aimed at restoring perfusion to actually provide the cells with glucose and oxygen. And that's the main thing, is that whatever glucose you have, you want to mix it up with oxygen inside the mitochondria of the cell so you can actually go through oxidative phosphorylation. And what this means is that you're running your little engines in every cell so they can actually stay alive. Oxygen delivery to the cells is critical and requires breathing in an adequate amount of oxygen, diffusion of oxygen from alveoli to pulmonary capillaries, oxygen transport to the cellular level, and release of oxygen at the cellular level. So basically, all these have to happen in order for you to actually get oxygen to the specific cells, including the brain cells. Etiologies of shock. And what it means is etiology is like what causes shock? What are the reasons that you get shock? Poor tissue perfusion is caused by one or more of these problems. Inadequate volume. In other words, you don't have enough blood in your system, either because you have an open blood vessel that is leaking that blood out. If it's external, you can see it. If it's internal, you have to suspect it. The other one would be dehydration. I mean, I saw a meme where the guy walks outside, and as soon as he steps into the sun, they show what do you call it, a death certificate of him. Now, the other one is that if your heart is not functioning correctly, let's say you had a heart attack and it doesn't function correctly anymore, then you can actually get shock or inadequate vessel tone. Now, this happens because of medications. It could happen because of trauma or whatsoever to the spinal cord, which basically dilates the blood vessels, causing the blood pressure to drop. Remember, the name of the game at this point would actually be the maintenance of blood pressure. Excuse me. Inadequate volume can actually be caused by decreased blood volume, decreases preload. Decreased preload causes stroke volume and cardiac output to fall. Decreased cardiac output causes a drop in systolic blood pressure, and a decrease in systolic blood pressure results in inadequate tissue perfusion. Inadequate volume may result from loss of whole blood or plasma volume by bleeding, vomiting, diarrhea, excessive urination, and increased capillary leakage. And the increased capillary leakage is when you have like an anaphylactic reaction that you start swelling up. A patient requires an increase in blood volume. If red blood cells have been lost, there is a decrease of oxygen carrying capacity as well as a decrease in pressure and perfusion. So inadequate pump function is basically the heart fails as a pump regardless of the blood volume. The delivery of the oxygen and glucose to cells is decreased. Okay. Inadequate pump function may actually occur from myocardial infarction or heart failure or mechanical obstruction of blood flow. You have pericardial tamponade, which basically is that sac that surrounds the heart starts getting filled up with blood, compressing the heart, making it smaller. So what happens is that you're not pumping enough. The tension pneumothorax is basically when one of your lungs actually collapses and is retaining air in that's actually going in, causing the heart, let me see if I can draw this, causing the heart to be compressed by the tension itself. So let's see if you have normal two lungs, right? The heart's located right here. And if you decide that you want to go ahead and cause this to actually go down, in other words, to collapse, and air's still going in, but it's filling up the cavity itself, causing the lung to become a lot smaller. Okay, eventually that pressure is going to push everything this way. And when it does that, it compresses the heart. Okay. In some cases, giving fluids might actually worsen the condition because, well, the fluid itself is not being pumped out. Inadequate vessel tone, basically blood pressure, is a function of cardiac output and systemic vascular resistance. And systemic vascular resistance is the constriction and dilation of your blood vessels. If systemic vascular resistance is decreased from vasodilation, blood pressure is actually decreased also. So this blood vessel got dilated, causing the blood pressure to actually drop. So that basically reduces the blood pressure itself. Inadequate vessel tone, massive vasodilation can actually occur from a loss of the sympathetic nervous system, function, or chemicals released within the body itself. Treatment includes Treatment includes vasoconstriction and volume restoration. Inadequate vessel tone, treatment of shock depends on the underlying cause. Consider requesting a higher level up ambulance and ALS unit, but weigh the benefits against the potential delay in reaching the hospital. And the thing, in other words, if it's going to take longer for the ALS unit to get there, you might want to meet them halfway, if not just transport the patient with BLS. So this diagram here is very important, guys. This is basically, let me see if I can. This is basically all the reasons that you have shock. So shock can actually be caused by hypovolemic measures. You don't have enough fluid in there. Distributed shock, basically, what does this mean? Okay, that you cannot distribute the blood volume because there's a dilation of blood vessels. Obstructive shock is usually caused by tension pneumothorax, pericardial tamponade, or pulmonary embolism. Now, of course, we have cardiogenic shock that's caused by congestive heart failure, myocardial infarction, a depressed pump function from abnormal rhythms, or beta blockers, which basically they're given to patients that have hypertension. Now, at this point, you also have metabolic or respiratory disturbance in oxygen diffusion, carrying of loading of by the cell itself. So you need to know all those. Memorize them. You're gonna get questions like you have a person that's bleeding internally, what type of shock is that? So categories of shock, you have hypovolemic shock is caused by low blood volume. Hemorrhage is the most common cause of hypovolemic shock, also caused by burns and dehydration. Burns because they actually leak plasma. In dehydration, you're losing all the fluid in your system. We also have hemorrhagic hypovolemia, where basically you cut a blood vessel and then you start losing it. Now, the other ones that non-hemorrhagic hypovolemia is loss of plasma through the capillaries because of whatever reason, let's say an anaphylactic reason or whatever. Distributive shock is caused by vasodilation loading to a relative reduction of intravascular volume. Can also involve loss from increased capillary permeability. Cardiogenic shock is caused by the inability of the heart to actually contract effectively. Generally occurs at the loss of 40% or greater of the left ventricular volume. Stroke volume and cardiac output are actually reduced, causing the blood pressure to go down. Damage to the heart, like a myocardial infarction. If you have an ischemic state right here or an infarct state right here, then that piece of heart does not work. And if it doesn't work, it doesn't pump out the amount that it should be pumping out. Obstructive shock results from a condition that actually occurs forward blood flow, causing include pulmonary embolism, tension pneumothorax, and pericardial tamponade. Treat by relieving the obstruction itself. Now, in the basic level, it's going to be kind of hard. I know that there was an old treatment that we used to use, and we'll elevate the legs, but we'll put the patient on right-sided lateral recumbent to actually release an embolism. Pulmonary embolism. In this case, you have a blood vessel actually being occluded and not returning blood to the heart itself. Tension pneumothorax, you have the pressure in the cavity pressing against the heart. And then you have pericardial tamponade, where the heart itself, the sac, is getting filled with fluid or blood, causing the heart to actually compress. Cardiogenic shock, metabolic or respiratory shock. Some sources list metabolic or respiratory shock as the fifth category. Dysfunction of the ability of the oxygen to be diffused into the blood, be carried by hemoglobin, outflow into the cells, and used effectively by the cells for metabolism. Specific shocks, you have hemorrhagic shock, which basically is you bleeding out. Loss of whole blood results in decreased perfusion and treats by stopping the bleeding. Specific types of shock, non-hemorrhagic hypovolemic shock, loss of fluid without loss of red blood cells can result from vomiting, diarrhea, or sweating. Administration of IV fluids can actually be helpful. Burns and shock is a specific form of non-hemorrhagic hypovolemic shock resulting from a burn injury. Plasma proteins leak and damage from damaged capillaries. Then you have loss of fluid causing the oncotic pressure that leads to actually edema, but you're going to be losing that fluid to the interstitial space, not keeping you within the blood vessel. Anaphylactic shock, chemical substances released by anaphylactic shock. Reaction caused massive systemic vasodilation and increased capillary permeability. Epinephrine is the medication of choice in this case. Septic shock is shock by another type of blood loss or distributed shock. You have bacteria and toxins in the blood lead to actually vasodilation and increased capillary permeability. Patient can actually benefit from ALS treatment, which is advanced life support treatment. So we have this scale here, which is basically it's a screening scale to find out how how bad the shock is, or sepsis. I'm sorry, not shock. So Robson's screening tool, basically sepsis is suspected in 2 of the following findings and presented with suspected active infection. So the temperature is above 100 degrees or below 96.8. Heart rate is above 90 beats per minute. Respiratory rate is greater than 20 per minute. Acute altered mental status, and they have a blood glucose level of lesser than 120. The BAS, a 90-30-90 scale for sepsis is suspected in 1 or more of the following findings are present in the patient with suspected active infection. Systemic blood pressure less than 90, respiratory rate greater than 30, and SpO2 level lesser than 90%. The Q-SOFA score basically is a suspected if 2 or more of the following findings are present in a patient with suspected active infection. Respiratory rate of 22 breaths per minute, altered mental status, a Glasgow Common Scale less than 13, and systolic blood pressure 100 millimeters of mercury or less. Types of shock. Neurogenic shock. This is basically caused by spinal column damage. So spinal cord injury can actually cause a sympathetic nerve fiber functions responsible for maintaining blood pressure tone. So basically what they do, once you get that injury, your blood pressure drops because there's no signal to the blood vessels to actually stay constricted, so it dilates. And you suspect that in like back injuries. Loss of systemic vascular resistance usually occurs. So basically, your blood vessels dilate. Cardiogenic shock is caused including acute myocardial infarction, congestive heart failure, abnormal cardiac rhythm, and overdose of certain drugs. Patients can actually benefit from ALS interventions at this point. Now, question. Let's see if you guys can actually figure this one out. Click on what best describes the type of shock that occurs when there is massive systemic vasodilation. Massive systemic vasodilation. Would it be obstructive, metabolic, distributive, or cardiogenic?
You can do a D or D.
Okay, but if it's massive systemic vasodilation, I would go with distributive. So cardiogenic is the heart not pumping enough. Obstructive is if you have remember you have a pulmonary embolism or you have a pericardial tamponade or tension pneumothorax. And metabolic would be more of a situation where you have your adrenal glands not functioning correctly or whatsoever. Shock. The body's response to shock. The body attempts to actually compensate to return perfusion to normal. And what it does, it increases the pulse. Well, the first thing it does, it vasoconstricts the blood vessels automatically. So that brings up the blood pressure. And then once it starts losing it, it starts increasing the pulse rate. Many signs and symptoms of shock are related to compensatory mechanisms. The sympathetic nervous system stimulation and release of hormones are the 2 major compensatory mechanisms that we can find. Direct nervous stimulation, the effect of sympathetic stimulations are immediate. You have an increase in heart rate, increase in force of ventricular contraction, vasoconstriction, and stimulation of the release of epinephrine and norepinephrine from the adrenal gland. Okay, the effects of hormones are more sustained. Epinephrine has alpha and beta effects that actually cause vasoconstriction and increase in cardiac output. So what this does, it causes vasoconstriction to maintain blood pressure, but it also increases cardiac output, which basically causes the heart to contract a lot stronger. Norepinephrine has alpha effects that cause vasoconstriction, and other hormones also may be released. So Alpha 1 receptor. Now, this is something you also have to memorize. Alpha 1 receptors, contraction of the muscles controlling the heart causes contraction of the muscles controlling the iris. Okay, and basically causes dilated pupils. Contraction of vascular smooth muscle causing vasoconstriction, and basically have pale, cool, clammy, narrow pulse, and pressure, and stimulation of sweat glands, which actually localize sweating and clammy skin. So that's when you have somebody that's suffering from a heart attack, you find them in respiratory distress. You see them sweating also because it's affecting uh, the alpha 1 receptors. Beta 1 receptors increase in heart rate, you get tachycardia. You have an increased speed of impulse through the conduction system, and which causes tachycardia. Increased force of contraction, which causes a pounding heart. Beta 2, you have bronchial smooth muscle dilation, which decreases the resistance in the airway. And you have skeletal muscle contractility and tremors. Epinephrine increases their heart rate, so it has beta 1. It also increases contractility, which has beta 1. It causes vasoconstriction, alpha 1, and it decreases insulin secretion, which is alpha 2. So you have a low amount of insulin being released, you're going to have a high glucose level. And the conversion of non-carbohydrates into sugar, which is what glucagon does, and the iris actually muscle contraction, alpha 1. Norepinephrine is a vasoconstriction, alpha 1, sweat gland stimulation, alpha 1, and increase in heart rate, beta 1. Antidiuretic hormones, also known as vasopressin. It increases sodium reabsorption in the kidneys, and it decreases the urine output. You have vasoconstriction, you have an increased blood pressure. Angiotensin 2, which is causes high blood pressure. Sodium reabsorption into the kidneys, and it decreases urine output. Aldosterone, sodium reabsorption in the kidneys and increases urine output. Glucagon, conversion of stored glucose in the liver to blood glucose. The conversion is of non-carbohydrate into sugars, and you have an increased heart rate and contractility. Stages of shock, compensatory, decompensatory. Compensatory is when you're actually maintaining blood pressure and pulse. Decompensatory is when you lose that control. Blood pressure starts going down. So basically all this is cycles, and basically all it tells you is the more you bleed, the more you're gonna, the lower your cardiac output's gonna get. Stages of shock, compensatory shock, which basically is that body is able to actually maintain near normal blood pressure and perfusion of vital organs. Blood is shunted away from the non-vital organs, such as the skin and gastrointestinal tract. You have a pulse pressure may actually be narrowed. Non-compensatory shock, you have non-compensatory mechanisms are overwhelmed. The body can no longer maintain blood pressure and perfusion of the vital organs, and you have anaerobic metabolism is occurring. Vital organs are not perfused at this point. Then you have stages of shock. You have multi-organs dysfunction syndrome, also known as MODS. And basically what happens is if you don't perfuse your tissue, organs start dying. That's all it is. So sometimes it's referred to as irreversible shock. Signs may actually, shock assessment signs may actually be subtle or profound, but rapid recognition of shock is key to treatment. Consider history findings, physical assessment findings, signs of perfusion, disturbance, and vital organs. Do not rely on one finding or signs and symptoms. Take a history. Remember the history is chief complaints, the sample history itself, and beta blockers or calcium channel blockers can actually alter the response to shock. So you're getting medication that might actually change what the body's supposed to be doing to compensate. The physical exam, vital signs can actually appear normal in compensatory shock. Look for signs of poor perfusion. Now, what would be a sign for poor perfusion when you're dealing with a patient that has a pulse rate of 120 and a blood pressure of 120 over 80? What would tell you, hey, this guy might not be doing so well? Well, capillary refill, telltale sign.
Sir, what was the question?
What would be the signs and symptoms that a person might be showing that they're having poor perfusion if the body's going through compensatory mechanisms? Let's see, his blood pressure is 120 over 80 and his pulse rate is over 100. Well, check for capillary refill, check to see if there's any cyanosis, check to see if he's pale. Those are all telltale signs. I mean, even though the blood, because you can rely yourself on, on looking at the blood pressure and the pulse, well, they seem kind of normal, but then why is he cyanotic? Why is his capillary refill at 6 seconds? Well, the body's trying to compensate. So, I mean, those are little hints. Okay. Stages, indicators for hypovolemic shock. You have a decreased blood pressure, anxiety, anxiousness, and progresses to decreased mental status. Narrowing pulse pressures. You guys remember what narrowing pulse pressures are?
No, sir.
Narrowing pulse pressure is the difference between the systolic and diastolic blood pressure. Oh, come on. Let's see. So you have a blood pressure, you take it 3 times. You have a blood pressure of 120 over 80. Second time you take it is 110 over 90. And the third time you take it is 100 over 95. So all this means is that the difference between these numbers is getting smaller. So you subtract these two, you got 40, you got 20, yeah, 20, right? Yeah. And then you got 5. So that number is getting smaller and smaller and smaller. That's all it means. Tachycardia, delayed capillary refill, tachypnea, which is rapid breathing, weak or absent peripheral pulses, pale, cool, and clammy skin, which you have a decrease of urine output also, and you have unavoidable or poor or unobtainable or poor SpO2 level. And the reason the SpO2 level doesn't read is because capillaries are shutting down, and our fingers are filled with capillaries. So if you don't have, if the capillaries are not being filled up, it's because there's no blood going to the fingers. Decreasing blood pressure, anxiety, anxiousness, progressive and decreased mental status, narrowing pulse pressure, pale, cool, clammy skin, cyanotic or mottled skin. Tachypnea or bradypnea may actually be irregular, jugular vein distension, and peripheral edema. Tachypnea is weak or absent peripheral pulses. Oh, sorry. Pale, cool, clammy skin, cyanotic or mottled skin. You have a decrease of urine output. You have a decrease of SpO2 reading also. Other signs, crackles, rails, and stuff that you can be hearing in the lungs. Decreasing blood pressure. You have anxiety, anxiousness, or distributive shock. Tachycardia and anaphylactic and septic shock. Relative bradycardia, normal heart rate. Shock is associated with spinal cord injury. And muddled cyanosis, late sepsis, anaphylactic, and neurogenic. tachypnea and respiratory distress, and wheezing or anaphylactic shock. They're weak or absent peripheral pulses. Tachypnea, you're also going to find weak or absent peripheral pulses. Normal respiratory rate and neurogenic, you're going to have normal flush to flushed, early sepsis, warm flush skin, neurogenic, warm flush skin with high possible cyanosis, it's anaphylactic, mottled cyanosis, late sepsis, anaphylactic and neurogenic, and severely decreased SpO2 level reading for anaphylactic. Other signs include fever, sepsis, loss of motor sensory function, and edema. Vital signs: decreasing blood pressure when it comes to obstructive shock, decreasing blood pressure, pulsus paradoxus. And pulsus paradoxus, all it is that if you're taking a pulse and you find it, and you take a person to take a deep breath, it kind of disappears. Narrowing pulse pressure, pale, cool, clammy skin, tachycardia, tachypnea, basically your jugular vein distension, pericardial tamponade, and tension pneumothorax. And with tachypnea, you have weak or absent peripheral pulses. Pale, cool, and clammy skin, cyanotic or mottled. You have a decreased urine output. You have a decreased SpO2 reading, severely decreases SpO2 reading, tension pneumothorax, and massive pulmonary embolism. Other signs of severe decreased to absent breath sounds of one hemithorax or tension pneumothorax. Okay. Age consideration in shock. Age may actually be influenced by the development of presentation management and the recovery from shock. Children can actually compensate well, but deteriorate very quickly. And I think I showed you a diagram last time we last year actually. And basically, adults, let's see, if blood pressure starts dropping, adults will actually drop it very slowly because they're compensating, okay, until you get to zero. With kids, the same thing, but once they stop compensating, blood pressure drops real fast. So kids tend to die a lot faster because they can't compensate. I mean, they can compensate, but they can't maintain their compensation. Now, geriatric patients, the same thing, do not actually compensate well. General goals of pre-hospital management of shock: secure and maintain the patent airway, establish and maintain adequate ventilations, establish and maintain adequate oxygenation, do not hyperventilate the shock patient, and stop bleeding as quickly as possible. General goals for hospital emergency management of shock: splint fractures, don't delay transport, do not remove an impaled object, maintain a body's temperature, keep patients supine, apply the mask bands according to protocol, and rapid transport and consider ALS intercept. Now, when it comes to resuscitation and cardiac arrest, it only means bringing the patients back from pre-hospital, from potential or apparent death. Resuscitation focuses on the management of the airway, ventilation, and oxygenation, and restoring adequate circulation. Cardiac arrest occurs when the ventricles of the heart are not contracting or cardiac output is ineffective and no pulse can actually be felt. Your brain cells begin to die within about 6 minutes. Cardiac arrest patients are described as having suffered a sudden death when the patient dies within 1 hour or of the onset of the signs and symptoms. A common cause of cardiac arrest is ventricular fibrillation, which is an abnormal rhythm that happens in the heart. Ventricular fibrillation can actually be treated with a defibrillator. Now, we carry the AEDs, so that's how you can actually get rid of that. But the AED needs to find out what it has, what the patient has. Patient goes and then pathophysiologic cardiac arrest. Patient goes through three phases of cardiac arrest that actually lead to biological death. Electrical phase, a dysrhythmia, circulatory phase, loss of blood pressure, and metabolic phase where basically your pH changes and your as your CO2 levels actually increase. Electrical phase, you have first 4 minutes, the heart still has supply of oxygen and glucose. Conditions are favorable for resuscitation. So having glucose and oxygen within the cells, you can actually shock and the patient can actually come back. The heart is prepared to respond to defibrillation. 4 to 10 minutes after cardiac arrest, oxygen stores are exhausted, myocardial cells switch to anaerobic metabolism. CPR is needed to restore supply of oxygen and glucose to enhance the possibility of successful defibrillation. Metabolic phase, you begin 10 minutes after cardiac arrest. The heart muscles is acidic and ischemic and begins to die. Chances of resuscitation are unfavorable. Okay, terms related to out-of-hospital arrest. Resuscitation, you have downtime, total volume, total downtime. That was how long have they been down? When was the last time somebody saw him alive? Return to spontaneous circulation, also known as ROSC. You should have heard that when you took your CPR class. Survival, witnessed cardiac arrest, or unwitnessed cardiac arrest. Do not resuscitate, now withhold resuscitation if they have a DNR. Physician orders for the life-sustaining treatment, medical orders for life-sustaining treatment, or injuries incompatible with life, like decapitation. Basically, the chain of survival is a slightly different for pediatric patients, and successful resuscitation depends on the sequence of events that we deal with, and you learn that in CPR. Now, ideally, the first thing is immediate recognition of and activation of 911, immediate high-quality CPR, rapid defibrillation, basic and advanced emergency medical services, and advanced life support and post-arrest. Prevention of arrest, early high-quality CPR. You have also rapid activation of EMS. It takes effective advanced life support and rapid transport and integrated post-cardiac arrest care. Now, when we defibrillate, ideally, look, I'm not going to go over every single one, but when we're trying to defibrillate, what we're trying to do is cause a reaction by the cells in the heart. The cells in the heart actually have this thing called automaticity. And if they still have oxygen and carbon, and oxygen and carbohydrate, which is a glucose, then defibrillation works. Okay. So when you defibrillate, you want to go, initially you want to go ahead and start CPR, because whatever blood's being stagnant in the heart itself needs to circulate. So you need to do chest compressions plus oxygen administration. Without this intervention, ventricular fibrillation degenerates into a systole, or the ventricular fibrillatory wave. Push hard, push fast to provide effective chest compressions and CPR. Compressions are at a rate of at least 100 beats per minute. Now you have compression to ventilation rate of 32, minimize interruptions in defibrillation, remember no more than 10 seconds, and avoid excess ventilation. Manual defibrillators require extensive training use. It's done by the paramedics, but you guys can use the automated defibrillators. Okay, advantages of AEDs: speed of operation, safer more effective than shock delivery, and use of efficient monitoring. Types of defibrillators: you have the AED, fully automated, and the semi-automated. The AED may use a monophasic or biphasic. And a monophasic, basically, the signal goes from point A to point B, and in biphasic, it goes from point A to point B, and then point A secondary to point B, or point A to point B and point B to point A. The way the signal actually gets through. We have a picture of the defibrillator. The pads themselves, these are pediatric pads, and these are adult pads. I'm sorry, both pediatric pads. I'm sorry. And you have the adult pads also. Analysis of cardiac rhythms, ventricular fibrillation, and this is what this machine actually does. It tells you if it's ventricular fibrillation or ventricular tachycardia or a systole. Now, if there's what we call a pulsus electrical activity, then it'll show up as pulsus electrical activity, but it's also known as PEA, but you will not have a pulse. In other words, if you're looking at the monitor. So that's why the defibrillator itself, the AED will tell you check for pulse, just in case it's one of these. Ventricular fibrillation, basically all it is there's a lot of cells within the ventricles that are misfiring, and they cause this type of irregular type of wave. Tachycardia, if you think about it, they look like shark's teeth. Okay, and you have specific areas and the ventricles shooting faster than they're supposed to. You're only supposed to get a signal going through these pathways right here. But if you have everything going on, then you might actually get ventricular tachycardia. Assisted is when you don't have any signals whatsoever. The heart is dead. Okay, analysis cardiac rhythms. No one should touch the patient when you're actually ready to shock, because you'll shock that person, your partner. Any type of movement interferes with the analysis, and the electrical energy can actually be transmitted from one touching the patient themselves. So you might actually, now ideally, when you shock somebody, you forcibly make them go into cardiac standstill, and you basically wait for it to reset itself. If you're touching the patient, you're going to get the same thing. So it'll stop your heart. The AD scans for use in patients with all ages. Manual defibrillation is preferred to those who with less than 1 year of age. And dose attenuating system is preferred to the use of in children, and use adult pads when children greater than 8 years of age. And actually, it was going by weight, not age. Assessment-based approach to cardiac arrest. Scene size up and primary assessment. If the patient appears unresponsive without signs of life, quickly check for breathing and carotid pulse. Assess for no longer than 10 seconds. Remember, the magic number is 10. And the patient is apneic, has agonal respirations, begin CPR with CAB. In other words, compressions, airway, and breathing. Okay. Patients less than 1 year of age, the heart rate is greater than 60, with inadequate ventilation, assist provide ventilations at 12 to 20 per minute. If the heart rate is less than 60 or a pulse is absent, begin chest compressions. Patient less than 1 year of age, 30 compressions to 2 ventilations. For 1 EMT performing CPR, 15 compressions to 2 ventilations for 2 EMTs performing CPR. Patients of 1 year of age to puberty, 30 compressions, 2 ventilations for 1 EMT performing CPR. 15 compressions, 2 ventilations for 2 EMTs performing CPR. Adolescents with signs of puberty and adults, 30 compressions to 2 ventilations, rate of at least 100 beats per minute. Compressions depth is at least 2 inches, and for an obvious pregnant patient, displays the uterus laterally when giving compressions. Secondary assessment, attempt to obtain a history from bystanders or relatives, but do not interrupt chest compressions or delay defibrillation. Continue CPR and defibrillation as indicated. Once the perfusion is restored, continue reassessment, and patients may actually revert into cardiac arrest. It's not long as I'm going to tell you one thing. It's seldom that somebody comes out of cardiac arrest by doing compressions. Very seldom. Okay, using the AED, ideally at least 2 EMTs are present. Take standard precautions. Perform a brief primary assessment. Perform CPR, minimizing breaks. Remember, 10 seconds is a magic number. Prepare and apply the AED, analyze the rhythm, and defibrillate as recommended by the AED. So the AED is going to be telling you what to do. Emergency medical care, continue CPR and defibrillation as indicated. Reassessment, once perfusion is restored, continue reassessment. Patients may actually revert into cardiac arrest after this case. Okay, ideally, at least 1 EMT is present when using the AED. Take standard precautions, perform a brief primary assessment, perform CPR, minimizing breaks, prepare and apply the AED, analyze the rhythm, and defibrillate as recommended by the AED. Check for carotid pulse. Chest compressions while they're setting up the AED. Now, this is very important. You want to get chest compressions while they're actually setting up the AED, because you're trying to circulate that blood. Turn on the AED, attach it to the patient. And then when it's analyzing, don't touch the patient. And when you're about to shock, don't touch the patient. Okay, and then you continue CPR and you ventilate them. Check for carotid pulse every cycle, every 5 cycles. It'll tell you when to do it. And then basically find out if it actually came back. Now, using the AED by a single EMT, simultaneously verify that the patient is unresponsive with no breathing and no pulse. Call for additional EMS backup and ask for an AED. Immediately begin chest compressions and apply the AED as soon as possible and minimize interruption and compressions. Number 10 seconds is a magic number. A pregnant patient in cardiac arrest who is at 20 weeks of gestation or more, it is necessary to actually place the patient supine position and to manually displace the uterus nose, push the stomach to one side. A brief emergency care procedure and operating the AED if ALS is not responding to the scene transport. If the patient regains a pulse, or your protocol indicates transporting after a prescribed number of shocks or no shock indicated message. Provide oxygen ventilation as needed. Have suction already. Transfer the patient to the ambulance. Consider getting ACLS to the patient. Keep the AED attached and perform secondary assessment and reassess every 5 minutes. If you're transporting a patient without pulse, continue CPR all the way through. Follow your protocol. Use extreme cautions when defibrillating in the ambulance. And rendezvous with somebody that's an ALS unit or whatsoever. Post-resuscitative care, indications of ROSC. A pulse is felt after the AED indicates no shock. Advisory, a patient regains spontaneous breathing and the patient begins to move. Upon ROSC, that says the patient's ventilation, avoid potential oxygen toxicity issues. In other words, do not give them that much oxygen. Okay, basically minimize the time from the delivery of the shock to defibrillation, of CPR to defibrillation to the arrival of ACLS units. Now, these are basically kind of pictures of what we can tend to see with a person that has an internal pacemaker or an implanted pacemaker, right under the skin. Special considerations. Automatic implanted cardioversion defibrillator detect the rhythm, disturbance, and deliver shocks. Do not place the AED pads over the ICD. It's an internal cardioverter defibrillator. And it's the one where it's shocked, the patient gets shocked by his own device. If the ICD is operating, 30 to 60 seconds for it to actually complete the cycle before attaching the AED. Mechanical pistons devices, these are basically CPR giving machines. We have this device, which is the life band. Basically, it just constricts, and it gives compressions to the patient without you having to worry about it. Okay, so we're going to continue to the next one. Where am I? Which is chapter 16, respiratory emergencies. Now, what I'm going to do, I'm going to take a little break so I can get some water. Okay, so I'm going to go ahead and give you 5 minutes. Okay, let's continue with chapter 16, which is respiratory emergencies. Hey, what happened to Eddie? Okay, respiratory distress is frightening and potentially life-threatening. You must be able to actually recognize signs and symptoms of respiratory distress and provide immediate intervention. The respiratory system consists of upper airway, lower airway, and lungs, and the normal breathing is normal respiratory rate is based upon the patient's age and medical history. Certain findings are consistent with a person who is actually breathing or adequately. Abnormal breathing, conditions that impair gas exchange, increase space between the alveoli and pulmonary capillaries, basically and the alveoli actually swell up. Lack of perfusion of the pulmonary system from the right heart. In other words, if there's not enough blood being taken to the, to the right heart to the lungs, or fluid and shock or pus in the alveoli, which is basically is indicative of infection or damage. Abnormal breathing while assessing breath sounds. Auscultation of breath sounds provides additional evidence of breathing difficulty. To achieve the most accurate breath sounds, it is important to auscultate in the appropriate fashion. Have the patient sit upright and use the diaphragm end of your stethoscope over the bare skin. So when you're auscultating the chest, you go to midclavicular because it's in the middle of the clavicle. You check the right side and compare it to the left side. Then you go to mid-axillary, compare the right side to the left side and mid-axillary. And then you go to the back where you mid scapular, which is in the middle of the scapula itself, which is a shoulder blade right here. You check one side, to this side. Now you kind of want to check under the scapula itself, so you can get a better sounding sound from the lungs. And remember, when you're actually doing this, request the patient to breathe. Take a deep breath. Now, for whatever reason, they do this automatically. Whenever you put a stethoscope on their chest, they automatically go like, I don't know why, where they got trained, but I noticed that. Abnormal breathing, assess breath sounds. Abnormal breath sounds, wheezing, rhonchi, and crackles. Inadequate breathing leads to hypoxemia and hypercarbia. Hypoxemia, that means low levels of oxygen, and hypercarbia is high levels of CO2. Hypoxemia leads to cardiovascular failure and hypoperfusion. Untreated Inadequate breathing leads to death. Now, hypoxemia, again, low levels of carbon dioxide, low levels of oxygen leads to cardiovascular failure because your heart's not getting any oxygen. Simple as that. Common findings in respiratory distress: complaint of shortness of breath, breathlessness, increased or decreased pulse rate, changes in breathing rate or depth, or skin color changes. Causes: narrowing of bronchioles from inflammation, swelling, or bronchoconstriction. Bronchodilators can actually provide relief. Injuries to the head, neck, face, spine, chest, or abdomen, and cardiac compromise and hyperventilation. Other causes of respiratory distress: abdominal conditions like dysfunction of the respiratory system by mechanical disruption of the airway, lungs, or chest wall, stimulation of receptors in the lungs, and inadequate gas exchange related to the ventilation or perfusion disturbance. Respiratory distress. Okay. Adequate rate and tidal volume. Patient is compensating. Administer oxygen to maintain an SpO2 level greater than 94%, and consider CPAP. Respiratory failure rate, tidal volume, or both are inadequate, and they're not breathing deep enough. Assist ventilations with bag valve mask. Provide supplemental oxygen, and may deteriorate to respiratory arrest. Respiratory arrest. Cessation of respiratory effort leads to cardiac arrest in minutes. Immediately intervene with bag valve mask, ventilations, and supplemental O2. Now, there are many causes of respiratory distress, but assessment and basic emergency care is the same. So emphysema, bronchitis are emphysema and bronchitis, chronic bronchitis, are what we define as chronic obstructive pulmonary disease, or also known as COPD. Now, they sometimes also mention asthma. Okay, and then you have a diagram of what the bronchial is, the terminal bronchial to the alveoli, which is considered normal. When you have a decreased surface area, when the alveoli actually swell up, that makes it thicker for the oxygen to actually cross over to the capillary beds that are surrounding it. Now, at this point, when you have mucus plugs, as in the case of bronchitis, it tends to cause air to go in, but not to escape. And what happens is this actually starts stretching out more and more and more and more. And what happens with that, you develop a vula, which basically develops into emphysema. Pathophysiology of emphysema: you have lung tissue loses its elasticity because it got so stretched out, it cannot contract anymore. And then, you start getting into the cellular levels where you have a specific type of white blood cells that will actually go in there and cause, what do you call it, a fibrous tissue to actually does not expand and closes up anymore. Also, the alveoli are destroyed, disruption of gas exchange occurs. The patient purses their lips while actually exhaling to actually create their own physiological positive, a PEEP, which is basically a mechanical device that will actually cause you to breathe better. Patient usually complains of shortness of breath upon exertion. Signs and symptoms: many signs and symptoms of emphysema are similar to those related to respiratory distress. So you're going to have somebody actually sitting up in the tripod position. Notice this: he's got cigarettes. He doesn't have an oxygen tank, and he's got a bronchodilator or a metered dose inhaler. You have this device called the CPAP, which actually may improve oxygenation by putting on the patient, but a lot of patients might not be able to tolerate it. And it goes very tight to where when they take a breath, it pushes it a lot deeper. Chronic bronchitis swelling of the and thickening of the bronchi and bronchial lining. Alveoli remain unaffected by the disease associated with smoking. Narrowed bronchioles reduce airflow and reduce lung ventilations with increased lung fusion. You're
Sir,
gonna
can
have,
you hear me now?
yeah. Why?
Okay.
You've been talking or what?
Yeah, I was using my headphones, but I think the microphone on my headphones is broken.
So whenever you're playing Gods of War or whatever, they don't get to hear you.
No, I was at the gym with my headphones on.
Oh, no problem. Don't worry about it. So chronic bronchitis assessment, you have a productive cough. In other words, you're coughing up mucus. And when they say non-productive, you're not coughing up anything. You're just coughing. The increase of bronchial obstruction, there is a reduction in the residual volume of the lungs that actually can lead to bloating and cyanotic appearance. Chronic bronchitis, emergency care, same guidelines as any potential suffering from difficulty breathing. As COPD patients can actually develop hypoxic drive, maintain an SpO2 level greater than 88 to 92%, and you consider the use of a CPAP to give them more oxygen. Asthma. Remember I told you that some books actually claim asthma as being part of a COPD. I learned it that way. They would increase the sensitivity of lower airways that can actually lead to narrowing of the bronchioles and increase resistance to airflow. You have bronchospasms, edema of the airways, increased mucus production, acute severe asthma of status asthmaticus is a prolonged life-threatening attack. So asthma, basically all it is when the bronchioles get swollen up, they produce mucus, and the mucus itself prevents any air from escaping. Asthmatics don't have a problem taking in oxygen. They have a problem releasing that CO2. So usually you have asthma assessment, you have slow onset asthma. 80% of the cases of asthma have a slow onset. Deterioration is over 6 hours to several days, more prevalent in females, and usually triggered by upper respiratory tract infection. The leading signs and symptoms, learn the signs and symptoms of these slow acting. Rapid onset is 20% of the cases of asthma have a rapid onset, or it's very quickly. Deterioration of less than 6 hours and more prevalent in males. So females are going to have slow onset, males are going to have a fast onset. Usually triggered by allergens, exercise, or stress, and learn signs and symptoms of this. Asthma assessment, you have rapid onset asthma, more likely to result in death because it happens very quickly. Be prepared for this patient to develop respiratory failure or respiratory arrest. Critically ill patients require positive pressure ventilation with supplemental oxygen. Asthma emergency care, primary assessment intervention, supplemental oxygen to maintain an SpO2 level 94% or above. Allow sufficient time for exhalation when providing positive pressure ventilation. Consider CPAP and beta-2 agonists, which actually beta-2 are going to open up the bronchioles. Pneumonia, pathophysiology, you have acute infection, infectious disease of lower respiratory tract, causes lungs inflammation and fluid or pus-filled alveoli, and leads to ventilation disturbance and poor gas exchange. And what happens with this one, you have fluid building up because of the infection itself, which causes now air to have a hard time trying to cross over. Remember, the difference between pneumonia and the other two is that in pneumonia, you might develop in a typical pneumonia, you're going to develop a fever. Now, there are certain cases that are atypical, which means that you don't go to the typical aspects of infection. In pneumonia assessment, they usually look like crap. They look sick. They complain of fever and severe chills, and then you have the signs and symptoms that actually appear. Treatment, not usually associated with severe bronchoconstriction, supplemental oxygen to maintain an SpO2 level greater than 94%, and follow protocols for the use of a beta-2 agonist and CPAP. The beta-2 agonists, again, they're gonna bronchodilate the lungs. Okay, pulmonary embolism, pathophysiology, obstruction of airflow in pulmonary arteries. You have several factors increasing the risk, including immobility. Something that's not moving, and usually caused by a blood clot. I know the most common situation you're gonna get is if you're in a prolonged air flight, you have the chances of actually developing a pulmonary embolism. And now this is a clot that goes to the pulmonary arteries and causes the artery itself to not be able to get oxygen oxygen circulated within the lung tissue, so it doesn't return back to the heart. Other conditions that cause respiratory distress, pulmonary embolism assessment, sudden onset of unexplained dyspnea or chest pain, signs of hypoxia with normal breath sounds and adequate volume. They include lower leg assessment, and you're looking for deep vein thrombosis. Right? Okay. Other conditions that cause respiratory distress, pulmonary embolism treatment, open the airway and administer positive pressure ventilation, maintain an SpO2 level 94% and above, and include lower leg assessment to look for the deep vein thrombosis. Other conditions, acute pulmonary edema, often due to cardiac dysfunction, results in hypoxia, occurs when excessive fluid collects between the alveoli and the pulmonary capillaries, and the gas exchange is impaired. So the heart's not pumping out the blood or circulating the blood, which basically means that you're going to have fluid building up. And that fluid is going to occlude O2 from going to the capillaries. Acute pulmonary edema, basically acute means that it happens very quickly. You find crackles or signs of pulmonary edema. You auscultate lower lobes. Cardiac symptoms does not occur with ARDS, which is a respiratory distress, acute respiratory distress syndrome. Anxiety, combativeness, and confusion may actually complicate assessment. Treatment for this one. Positive pressure ventilations may actually be necessary. CPAP may be beneficial. Administer O2 and keep the patient in an upright sitting position. Spontaneous pneumothorax, which basically a sudden rupture of the visceral lining of the lung with a partial collapse of the lung. Now, gas exchange is impaired because you have one oxygen is collapsed, one lung that is collapsed. Risk factors include smoking, connective tissue disorders, and COPD. Causes of spontaneous pneumothorax, in which air enters the pleural cavity and actually starts compressing the lung and whatever are the structures and moving it to one side. Pathophysiology, primary spontaneous pneumothorax occurs in patients who have no underlying lung disease. Secondary spontaneous pneumothorax occurs in patients in which there is an underlying lung disease. Now, I can tell you emphysema. Emphysemas, the patients have a real good chance of actually collapsing their lungs because of emphysema. And the only reason is because you start developing, let's see if I can draw this. When it comes to the terminal bronchiole itself, which basically lost now the elasticity, and it actually got bigger, as opposed to having it like this. Well, this, what we call a bulla, may actually be very close to the end of the lung. And if it gets close enough to where it stretches out, it will actually rupture it, and that's what we call a ruptured pleb, and causes air to escape from there. Okay, spontaneous pneumothorax shows with sudden onset, shortness of breath without evidence of trauma or decreased breath sounds to one side. When seated, absent breath sounds will be heard on the apex. And where is the apex of the lung? Basically, the upper portion of the lung. Conditions that actually cause respiratory distress, spontaneous pneumothorax treatment. If positive pressure ventilation is required, use the minimum tidal volume necessary. CPAP is contraindicated at this point because it can actually damage the lungs more. Hyperventilation syndrome, which is associated with emotional upset, excitation, and panic attacks. Breathing is faster and deeper than normal. Carbon dioxide levels decrease, and muscle cramps may occur in the feet and hands. And this one is what we start dealing with carpal pedal spasms, the cramps that occur in the hands and the feet. Assessment: the patient is true hyperventilation syndrome is in an emotionally charged situation. Calm the patient and get them to slow their breathing. Administer oxygen if the SpO2 level is lesser than 94%. Epiglottis or epiglottitis, I'm sorry, is infection of the epiglottis leads to swelling that can actually obstruct the airway. The epiglottis gets swollen up and it only has a certain amount of room to actually play around. And if it gets stuck, you're not breathing. Males and smokers are more commonly affected. And if it gets swollen up, it might actually get stuck and you're not able to breathe correctly. By the way, this thumb that's right here is your epiglottis. History of upper respiratory infection, usually for 1 or 2 days prior to onset. Inspiratory stridor is an indication of an almost completely occluded airway. Epiglottitis treatment: administer oxygen, keep the patient calm and comfortable. Do not inspect the airway and prevent ventilation. If ventilation is required, squeeze the bag slowly. Pertussis. Now, pertussis is a disease that made a comeback a few years ago. It's a contagious disease characterized by uncontrollable coughing, followed by a whooping sound. And it's like severe complications can actually lead to death. It's preceded by signs and symptoms of upper respiratory infection also. Pertussis assessment, 3 stages to recover. Stage 1, symptoms of common cold or upper respiratory infection. Stage 2, coughing continues to worsen to the point that medical care is sought. And stage 3, the recovery stage, usually gradual, taking several weeks. Treatment: place a surgical mask on the patient, of course on you too, position them comfortably, supplemental O2, and expectorate any mucus. Cystic fibrosis, and I saw a question on cystic fibrosis, which I was freaked out with. It's a hereditary disease affecting lung, digestive systems, and sweat glands. It occurs in young adulthood, usually from pulmonary failure. Production of thick mucus leads to repeated respiratory infection. Inhalation of toxins can lead to hypoxia by viruses. Mechanisms include upper airway swelling, displacement of oxygen in the atmosphere. This is poisonous exposure, I'm sorry. Damage to the alveoli and affects the body upon entering the bloodstream. Clinically, determinants: length of exposure, open to or closed spaces. If it's an enclosed place, then the concentration of whatever chemical is there is a lot stronger because it doesn't ventilate. Exercise grade personal caution when entering the scene for potential toxic inhalation. Treatment for poisonous exposures, limit exposure to the toxin, open the airway, position the comfort, oxygen at 15 liters per minute, in non-rebreather mask, positive pressure ventilation, and gather information about the poison itself. Viral respiratory infections includes colds, the flu, and bronchitis. And guess what else? COVID. It's a new one. Usually mild but significant infections can actually occur. Assess for and treat both hypoxia and respiratory distress. Viral respiratory infections maintain an SpO2 level greater than 94%. Supplemental oxygen and occasionally mechanical ventilations can actually become warranted. Contact the ELS for backup for medication administration in patients with potential deterioration. Now, in nebulizers, we use beta 2 specific bronchodilators can actually administered by metered dose inhalers or I forgot this SVN stands for metered dose inhalers or the other one. Basically, remember beta 2 is going to be respiratory. Alpha 1 is going to be cardiac. Bronchodilators cause relaxation of the bronchial smooth muscles. Medication is dispensed in aerosol or mist, and the patient inhales. Most bronchodilators begin to work almost immediately. Now, this is what we refer to as a metered dose inhalers. This is not a bronchodilator. This is a bronchodilator itself, a small volume nebulizer. That's what NVN stands for, small volume nebulizer. You put the medication here, and you connect it to oxygen source, and it actually atomizes it or mists it. Mists. Yeah. So medications for the nebulizers include albuterol, meroperidol, isoetheren, bilateral mesylate, salmeterol, foate, ipratropium, levalbuterol, and perbuterol. Indications: patients in hereditary distress, in respiratory distress, patients in physical prescribed medications, and approval from medical direction. Contraindications: patients do not have enough or then not responsive enough to actually not responding to the, patients is not responsive enough to use the medications. The medication is not prescribed for the patient. Medical direction has not given permission, or the patient has taken the minimum number of doses. Side effects: tachycardia. Most of these medications will cause tachycardia, tremors, nervousness, dry mouth, and nausea and vomiting. Now, the reduction of complaint of dyspnea, improved SpO2 level reading, normal respiratory effort, the patient becomes more alert when he's using the CPAP. Now, administering the medication, you verify the order from the medical director. At this point, make sure that the medication is right for the patient and the expiration date. You shake it for about 10 seconds or 30 seconds, You tell the person at the count of 3, I'm going to go ahead and press it, and you take a deep breath in. 1, 2. Ask them to hold it for as long as they can. Then exhale out. And then listen to lung sounds to see if the lung sounds have disappeared, and check for vital signs. The metered dose inhaler, there's a mouthpiece and a spacer. The spacer makes it go a lot deeper. Same thing, shake it for 30 seconds, make sure it's the right one, put it in their mouth and basically spray it in. It goes a lot deeper. Nebulize medications. At this point, listen to the lung sounds, do an assessment, um, basically get the medication. And most of these are, normally Sopanex or albuterol. You break it from the top, you put it in a little container, not inside this, but outside. Okay. Close it, attach it to oxygen, and mystify it. And what happens, you develop a little mist area where it's actually going to go in and affect the lung tissue. And then check for breath sounds and vitalize them again. Advair, not for emergency use. Advair is a long-acting beta-2 specific drug that basically it dilates bronchioles. It also contains steroid that is used for maintenance as a maintenance drug. Advair is not to be used with a rescue inhaler for the patient experiencing an acute asthma attack. Pediatric patients, respiratory failure is the most common cause of cardiac arrest or respiratory arrest. Common causes of upper airway obstruction and lower airway disease. You do a scene size up, primary assessment, look for clues to help rule out trauma. Breathing difficulty can actually be spotted as you form your general impression. Assess mental status, airway, breathing, and circulation. Secondary assessment, distress. Signs of respiratory distress typically precede failure to the infant or child. Recognize early signs and symptoms. Retractions appear to be more prominent early in respiratory. And acknowledge when they begin to use the intercostal muscles to assist in breathing. Secondary assessment, failure, you have bradycardia, hypotension, slow, fast, or regular breathing, and loss of muscle tone. Emergency medical care, allow child to actually assume a comfortable position. Do not remove child from the caregiver. Apply supplemental oxygen. If breathing becomes inadequate, remove them from the parent, establish an open airway, and actually begin positive pressure ventilation. Okay, have the kid hold the parent hold the kid so the kid can actually be calmer. Emergency medical care, upper airway obstruction on geriatric patients from body or disease, like croup or epiglottitis. Reassessment, transport any infant or child with difficulty breathing, provide reassessment and route, and be prepared to intervene. Respiratory distress has many causes of geriatric patients. Respiratory function may actually already be diminished and can actually progress rapidly from respiratory distress to respiratory failure. Do scene size up, primary assessment, look for clues to help rule out trauma, labored, noisy breathing, tripod position, unresponsiveness. Additional signs and symptoms will be discovered as you actually contact the patient. Secondary assessment, you have respiratory distress can actually quickly proceed to respiratory failure. Elderly patients decompensate very rapidly. It is difficult to actually, for the geriatric patient to move the rib cage themselves because it's gotten harder. Secondary assessment, respiratory arrest is a condition in which there are no respirations. If pulse is still present, you must immediately intervene and begin positive pressure ventilation. Emergency medical care, put him in a position of comfort. If the SpO2 level is less than 94%, or respiratory distress, hypoxia, hypoxemia, or poor perfusion are present, administer oxygen via nasal cannula. Reassess and route to the emergency department. The scene size up, look for clues to the condition, scan the scene for possible mechanism of injury, scan the scene for alcohol, which is common, attributed to choking in the upper airway obstruction and aspiration of vomitus because of the alcohol consumption. Primary assessment, form a general impression, assess mental status, assess airway, and assess breathing and assess circulation, and assessment-based approach to respiratory. Now, look for the position of the people. This is your typical tripod position. If they're in this type of position, then you have to worry about them being in the, what do you call it, respiratory distress. Stress-based approach, respiratory distress, primary assessment, check for mental status, look for restlessness, agitation, confusion, unresponsiveness. Airway assessment, assess the airway for any indications of complete to partial obstruction. Breathing, look at the chest for rise and fall, listen and feel for air flowing, auscultate the lungs, determine approximate respiratory rate. Shallow breathing is an indication of inadequate breathing. Inadequate breathing, provide positive pressure ventilation. Adequate breathing, administer oxygen. Primary assessment, assess circulation, inspect the skin and mucous membranes and assess for heart rate. Establish priority. Patient with difficulty breathing is a priority patient. Consider ALS backup and rapid transport. Do an OPQ-RST. Evaluate the chief complaint, allergies, medications, history, and hospitalizations for chronic conditions, which is basically OPQ-RST, just being more specific. Increasing respiratory rate. Basically, at this point, signs of deteriorating during the administration of CPAP. You have increasing respiratory rate, lethargy, or more groggy or not all there. Patients move more exhausted and fatigued. They're speechless. Abdomen moves inward in inhalation and outward in exhalation. You have a decreased SpO2 level reading also. When administering a meter dose inhaler, follow these tips. Do instruct the patient to breathe in slowly and deeply. Make sure the patient is breathing in through the mouth. Shake the canister for at least 30 seconds before removing the cap. And if the meter dose inhaler has not been used for a couple of days, prime and nose, pump out one pump before you put it on the patient. Depress the canister. Patient begins to initially inhale. Coach the patient to hold their breath. Use spacers or preferably a valve holding chamber device if available to the patients if used to it. Do not allow the patient to breathe in too quickly, and allow the patient to breathe in through their nose. Administer medication before shaking the canister. Depress the canister before the patient begins to inhale. Forget to coach the patient to hold his breath as long as possible, and the patient may actually experience a variety of side effects from the medication. The most common is an increased heart rate or tremors and nervousness. More detailed information you can find in 16-11. Secondary assessment, do a physical exam, look for cyanosis, JVD, tracheal deviation, and retractions. Auscultate lung fields or lung sounds for the lungs. Check vital signs for pulse oximetry. Look for signs of difficulty breathing and evaluate level of difficulty breathing. Physical exam, perform an accurate assessment. The severity of shortness of breath does not directly correlate with level of hypoxia. Inadequate breathing, establish an open airway, begin positive pressure ventilation, and transport expeditiously. Administer oxygen, assess baseline vital signs, determine if the patient has a meter dose inhaler, Place the patient in a position of comfort and complete the secondary assessment. Reassessment, look for improvement of or diminished in respiratory distress and respiratory failure. Assess the mental status and the airway. Provide positive pressure ventilation if needed. The patient with breathing difficulty is considered a low priority patient. Assess-based approach, respiratory distress, reassess and monitor respiratory rate and tidal volume, closely monitor the SpO2 levels, and monitor the heart rate. Okay, so we're done with these 3 chapters for today. Do you have any questions? Okay, so what I'm gonna do next Monday, we'll meet again and we'll go over, Monday, we're gonna be going over. Let's see. Give me a few seconds. Which should be chapter 15 and 16. We just finished with, oh, hold on. Did we finish with 14?
Yes, sir.
So it'd be 17 and 8, chapter 17 with us. I believe it's, can't remember what chapter 17 is. Oh, sorry, I have it here. Cardiopulmonary emergencies. So we'll attack that on Monday. All right. Well, you guys have a good, well, you have a good night. I don't know what happened to you.
I don't know what happened to Eddie. Ugh.